And next, I'd like to introduce our speaker, Emily Oake. Emily is the lead Special Populations Coordinator for the Arizona Alliance for Community Health Centers. Ms. Oake was born and raised in the Phoenix area. She received her BS in Political Science from Arizona State University. She worked in numerous retail management positions in the Phoenix metropolitan area before attending ASU to attain her Master's of Health Sector Management degree, which is the equivalent of a Master's of Healthcare Administration. During the course of her study, she worked as a research assistant for the co-director and founder of the Healthcare Supply Chain Research Consortium and as an intern for St. Luke's Health Initiatives. This internship was coordinated closely in conjunction with the Arizona Alliance of Community Health Centers and looked at the financial impact of eliminating health coverage for certain access populations in community health centers. Following completion of her master's degree, Ms. Oake was hired as an intern for AACHC to assist in coordinating the voter engagement campaign for the 2012 elections. Following the completion of this project, she was kept on to become the lead Special Populations Coordinator. This position serves as the point of contact for all health centers looking for training and technical assistance for any federally designated special populations. She also collaborates, plans, develops, and coordinates with other organizations in the state to increase resources available to special populations. In addition, she develops and maintains publications and social media presence to use for outreach activities and to increase awareness of issues affecting Arizona's medically underserved populations. Thank you, Emily, for presenting for us today, and I'm going to turn it over to you.
Okay, hello everyone. Thanks so much for attending. I did ask a question in the chat box to see if everyone could hear okay. I'm guessing since nobody said no that we're okay and good to go here. So we will go ahead and get started. So we are going to go over the CLAS Standards, which are culturally and linguistically appropriate services in health and healthcare. So these are the objectives, I believe, that were listed on the flyer that went out with this training, which are to understand the importance of culturally and linguistically appropriate services, demonstrating the ability to define key terms that relate to the CLAS standards, develop strategies for effective implementation, identify and use a variety of resources and tools for implementing culturally and linguistically appropriate services into your roles as community health workers, and demonstrate the ability to incorporate cultural competency into CHW practice and facilitate more culturally competent care and education. So first, we're just going to do a quick overview of what the CLAS standards are, some definitions of cultural competency, and some other terms that we will use throughout the presentation. So first, in order to understand what exactly the CLAS standards are, we will be using a term throughout the presentation called cultural competency. And there's many different definitions of this. We use this specific one just because that's how it's referenced throughout literature that we've used, but it's the ability to interact effectively with people of different cultures and helps to ensure the needs of all community members are addressed by being respectful and responsive to the health beliefs and practices of diverse populations. You may have heard other terms such as cultural humility, cultural intelligence, cultural empathy, sensitivity, or cultural responsiveness, amongst many others. So HHS kind of recognized the value of implementing cultural competency into healthcare practices and service delivery. So they developed this national set of standards to help organizations kind of infuse this into their policies and programs, and make sure that people were receiving the services that they needed. And they wanted to make sure that everyone was getting services that were responsive to the cultural and linguistic needs of everyone in order to reduce health disparities and improve healthcare quality. They also recognized that by implementing CLAS standards, organizations could end up saving the healthcare system a lot of money by reducing these health disparities. So the main overarching goal of CLAS standards is to advance health equity, improve quality, and help eliminate health disparities. And kind of some of the secondary goals that they hope to get out of this are increasing diversity in healthcare management, as well as governance and leadership, because they recognize that minorities have been underrepresented within healthcare management, as well as the leadership and governance of those organizations. So there's one principal standard, which is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. And in order to do this, they divided the rest of the standards up into 3 themes: governance, leadership, and workforce, communication and language assistance, and then engagement, quality improvement, and accountability. And there is sort of a legal precedent behind implementing some of the CLAS standards as well. Title VI of the Civil Rights Act in healthcare organization applies to hospitals, state agencies, public schools, nonprofits, etc. And they rule that it requires meaningful access to language assistance services, to train certified interpreters, bilingual staff, and volunteers, as well as translated vital documents. But not only is there a legal precedent, there is also additional value to your organization of implementing CLAS standards to maybe respond to demographic changes in the area that you serve, to eliminate some of the health disparities that exist in some of the population groups that you serve, to improve quality of services and outcomes, to meet legislative and accreditation mandates, to gain a competitive edge in the marketplace, and to decrease the likelihood of liability claims. The organizational framework for cultural competence kind of states that services should be integrated throughout an organization and undertaken in partnership with the communities that you're serving. And that's kind of where your role as community health workers comes in. You are the ones that are working most directly with the community members, as well as many of you may be from the communities that you're serving as well. Ultimately, the application and enforcement of CLAS standards relies upon strong leadership from managers and directors who prioritize cultural competency as essential to the workplace. I'm guessing many of the organizations that you work for do prioritize this. Unfortunately, you don't have a lot of direct control over that, but we'll kind of provide you with some tools and maybe some questions that you can ask of your own organizations to see what might already be in place. So what does culturally competent care in Arizona look like? We'll just give some basic information just to show you that there are different health disparities that exist between different groups in Arizona and what that kind of looks like. So again, just going back to our definition of culturally competent care, means being respectful, understandable, and which really leads to more effective care, which will increase patient satisfaction. People will utilize more appropriate services and be able to manage their own treatment a lot better. So they will adhere with their plans and overall improve their health status. So just a quick look at some of Arizona's demographics. On the left is population by race, and then on the right is population by ethnicity, either Latino or Hispanic or non-Latino or Hispanic. It's kind of estimated that by about the year 2050, the minority populations are expected to exceed the majority. So the demographics are shifting, throughout Arizona as well as the rest of the country. And just based on the very broad race and ethnicity categories, this is how people factor in as their kind of average health status. So if you look on the left side of the graph, Asian and white non-Hispanics have a better than average health status, while Hispanics are, slightly worse than average, while African Americans and American Indians face a much worse than average health status in comparison with everybody else. And again, within these groups, there's a lot of subpopulations. There are a lot of monolingual Asian populations in the United States that have, worse than average health outcomes. So this is kind of a very broad generalization of those very large groups of people. So what are health disparities? Health disparities are differences in the incidence, prevalence, mortality, and burden of disease and other adverse health outcomes that exist among specific population groups. These are all avoidable inequities in health status, healthcare access, health knowledge, etc. And when looking at kind of where health disparities come from, a lot of it is linked to your social, economic, or environmental disadvantage. And some examples of those, might be living in a lower income neighborhood where fresh food isn't readily available, or living in a rural area of Arizona where it's very difficult to travel to access any types of services, or maybe living in a more dangerous neighborhood where people may not feel safe going out on the streets and running or exercising or doing those sorts of things. And again, amongst those very large population groups, these are the leading causes of death. While there are very many similarities kind of in the top 2 causes of death for all populations, if you look at the individual numbers, the rates are much different. And there are certain things that affect different population groups differently. If you look at white non-Hispanics, they face a higher rate of chronic lower respiratory diseases than any other group. Or if you look at American Indians and Alaska Natives, they face a higher rate of chronic liver disease and cirrhosis. So what kind of leads to these different health disparities within the different groups? They've widely been linked, and it's kind of been more popular concept as of recently to look at, not only the regular things that people are looking at for health, but looking at these social determinants of health. All the conditions, including where people are born, where they live, where they work, all contribute to their health status in this country, as well as throughout the world. And these are shaped by the distribution of money, power, and resources at global, national, and local levels. So in order to address kind of these social determinants of health and eliminate health disparities, what we want to do is achieve the highest possible health equity for everyone that we possibly can. And equity and equality are very different terms that often get kind of used interchangeably. Equality would be giving everyone the exact same thing, regardless of what they needed. Equity would be giving everyone the right tools to promote, their own health status, as seen in this picture. Not everyone needs the same size box in order to see this baseball game. Everyone needs something slightly different. Some people might need more, some people might not need anything at all. So we want to make sure that we are, being fair in health distribution, access to care, so that everyone can achieve their full potential. So going right into the CLAS standards, now that we've kind of had some background information on why they might be important. So the first set Standards 2 through 4 talk about governance, leadership, and workforce. So it's engaging leadership in adoption of CLAS policies, recruiting, promoting, and supporting a diverse workforce, educating and training governance, leadership, and workforce if you happen to work for an organization that has some sort of board of directors. So as community health workers, what can you do within your own organization? And these are just some things for you to think about. What does your organization do, if anything, at a leadership level that promotes class or health equity? And that's something that you could ask the leadership within your own organization if you don't know what it is. If you do know what it is, then they're doing a great job of communicating that to everyone in the organization, and probably, in a much better position than other people. What policies, procedures, or processes about language access does your organization or program have? When someone comes in that speaks a language other than English, what does someone on your frontline staff do? What does one of your medical providers do? Does everyone know what they're supposed to do when somebody comes in and needs interpretation or translation services? So that's something that you could find out within your own organization. And does your organization set aside funds to support class and health equity? And for a lot of people, this is maybe a no, but if your organization is even providing money to utilize language line services, they technically do have funds to support class and health equity because they recognize that this is an important service for the people that you serve. So looking at staff diversity, what does your organization's staff look like? Are you representing the people that you serve? Does your staff look a lot like the populations that you're serving? While recognizing that the diversity of an organization's staff is a necessity, but not a sufficient condition for providing culturally and linguistically appropriate health services. Just because someone's bilingual doesn't mean that the staff is culturally competent and sensitive. There are many people that can speak another language that aren't necessarily familiar with the culture that goes along with that. Or sometimes, things that you may think are a direct, interpretation or translation, really wouldn't be said, in that way in another language because of the complexities of different languages. So there was a question about what other populations besides racial and ethnic minorities are part of the CLAS standards. That would be, anyone that faces, health disparities as a result of accessing care. It could be LGBTQ folks because they haven't traditionally felt safe coming into clinics or accessing services because, of fear of people not being accepting. It could be, elderly folks because they aren't able to, get in to receive services as well as other people. Or it could be economically disadvantaged people because they don't have transportation in order to, get and access services at the same level. It could be, different cultures viewing accessing healthcare differently. Some cultures, it's a very easy transition to make appointments and, be part of the American healthcare system. But for others, the healthcare system in their own countries is so different than how we access services in the United States that they may not do it just because they don't know what they're supposed to do. So here are some possible trainings that could be implemented within your own organizations. For all employees, you could have a cultural differences in the worksite training. For customer service or frontline employees or community health workers, if it happens to be you, working effectively with interpreter services when there are clients or patients that need those services. leadership and management. You could do application of laws that support the CLAS standards, which would be Title VI of the Civil Rights Act, kind of some other policies that are in place. There's Section 1557 of the Affordable Care Act that kind of expands to anyone providing vital healthcare services. They strongly encourage the development of a language access plan for your organization. They want you to put up a notice of non-discrimination in the top 15 languages for your state. So if your organization hasn't done that and you deliver a significant amount of services related to insurance enrollment or access, please let us know and we can help with resources that would help you support that. And human resources staff could go through some sort of implicit bias awareness and hiring training as well. So some of the strategies to build your workforce capacity would one be, emphasizing your role as a community health worker. You can help identify additional members from the community who you would think would make, great employees, or because you can teach someone the technical skills of working for an organization, but it's hard to teach that, respect and trustworthiness within people's own communities that a lot of people do have. So moving on to communication and language assistance, which are standards 5 through 8. This is probably where you can have the most direct impact. So making sure that your organization offers free language assistance, such as phone interpreters or sign language. A lot of organizations use the video remote interpreting services, and that way it covers all verbal languages as well as sign language. Informing people that they're able to get this assistance, ensure the competence of those that are providing the services, and providing educational and informational materials in other languages. So if your organization is receiving any federal funding, you must provide language assistance services at no cost to your clients or patients. So this would include any community health centers, since you are part of a federal grant program, anyone getting reimbursed by Medicare or Medicaid, because that's money coming from the federal government as well. So when the federal government kind of determines, what your obligation is as an organization to provide these language assistance services, they look at 4 different factors. The number of people eligible to be served or likely to be affected by the program or service. If you're providing services to a large population that are limited English proficiency, they'll want you to be able to demonstrate that you are providing services, in those particular languages. How often people are coming to you for services. The nature and importance of the program, activity, or service that you're providing. So emergency rooms of hospitals have a much larger obligation than, maybe a community resource program or a community referral program. And then the costs and resources that are available to your organization. So just looking at the census data on language spoken at home for populations over the age of 5 in Arizona, this is kind of the breakdown of the top languages spoken. However, we know that there's a lot of other languages spoken in this state. Particularly, I think Navajo is one of the top languages, and there's a lot of other Asian populations that are monolingual, that only speak, their native language at home, which may be Chinese, Vietnamese, Thai, amongst many others. And just in comparison with the rest of the states in the country, Arizona is one of the top 10 states with the largest limited English proficiency population. We have a lot of minority populations here. We have a huge refugee program that often brings in monolingual speakers from other countries. So we do have a very large number of people here. So when you aren't communicating with your clients or patients appropriately, it leads to kind of an ineffectiveness of whatever message you're trying to give them, whether it's changing, to healthier habits, whether it's making it into their next doctor's appointment, whether it's managing their chronic disease. If you aren't able to communicate with people effectively, people aren't going to, follow your instructions, which could lead to more, dangerous complications like not taking medication correctly, and those sorts of things. So, with the passage of the Affordable Care Act, although we don't know exactly what's going to happen with that, I mean, for now we continue to, proceed as if nothing's going to happen. Hospitals are going to, not be reimbursed at the same rates if they have lots of hospital readmissions. So that requires their patients to, for them to make sure that their patients are doing their follow-up care the way that they should be. So we have lots of resources and materials. This is kind of where we've done the most work with the Health Disparities Center at the Department of Health Services. We have an Arizona Health Alliance for Language Access Rights. That's the website there. There's a longer CLAS Standards training that people can do that we are still willing to go out to your organizations and do it in person, or you can sign up to do it online. And we had a question from someone regarding what LEP means, and that's Limited English Proficiency. So that could even be someone that speaks a little bit of English but doesn't speak it very well. They're more comfortable speaking in another language. So here's some of the materials that are on that website. Again, you can go to that link and utilize any of that stuff. Everything's free for you to download and print. I believe Hong still has copies of a lot of stuff. If you want hard physical copies, she can mail them to you. Kind of what we've found the most useful, we'll kind of snapshot on the next few slides. So the first one is this language identification list. So when patients come into your organization and you don't have someone on site, that can interpret for them, and you're having trouble, identifying what language they're speaking, because maybe it's something that you don't hear every day, they can point to their language on this list, and that way you can arrange for interpretation services. You can also hand out, once you've identified someone's language, handing out these I Speak cards. The one up here is Arabic, but I think there's about 15 or 20 different languages that are available on the website. There's also this kind of half sheet. This is front and back for people that are applying for access or a sliding fee scale, just to provide them some information about what those documents look like so they can more easily identify them when they come in for the eligibility process. There's a lot of community profiles up on the website as well, just to give some background information about people from countries that you might not be as familiar with, but we know that we have a large refugee population in the state. And again, these are like broad sweeping generalizations, so it's just some things to take into consideration. This isn't the end all and be all of how everyone is going to act or be part of this culture. And the other thing that's really important within communication is health literacy. Even people that English is their first language, they might not understand a lot of the very technical terms, either from being in a doctor's office or related to their health insurance. These might all be new concepts to them. Co-pays, deductibles, all those sorts of things. Sometimes when you're in a doctor's office and someone's giving you directions, you kind of space out and you don't remember anything that the doctor said. So being able to recognize that and make sure that when you are in a medical facility, that the patient is understanding and listening to, everything that you're saying, and you're doing it in as easy way as possible for the most people to understand. We've attached a few health literacy resources as well. This is the one that CMS put out. There's a lot of information about how to use health insurance. There's also kind of a little chart in the back to keep track of your personal health with blood pressure, cholesterol, vaccinations, if you've been screened for cervical cancer at any point, those sorts of things, and a tear-out sheet where you can keep all your health information close with your, health plan's name, your primary care provider's phone number, etc. And those are available in 10 languages, I believe, and there's the link on there as well. This is a tool developed by the IRC in conjunction with a few other organizations, just to help some of the refugees coming into the country keep track of their medical information, and when it's appropriate to call 911, when you should go to urgent care, when you should just call the doctor and make an appointment, or when you should just take care of it yourself. And this is kind of, all these things leading up to, trying to help people manage, their, primary care needs without utilizing the emergency room for everything, to help keep healthcare costs down. Since it was developed for refugees, it's kind of limited in terms of what language it's available in. However, you are more than welcome to, take the English one and translate it into Spanish if that's the primary population that you serve. There's also healthfinder.gov. If you enter your age and sex, which is a little limiting on there, you can find out, what preventive screenings you should have according to what is recommended. So I would enter, a 34-year-old female, and they would say, you should get a cervical cancer screening at least, once every 3 years, based on my risk factors. So just thinking about, what resources are available, what are ways that you could enhance communication, health literacy, or improve language assistance within your own organization? Maybe that's just making sure that everybody knows, what the language line number is, and that they can call, to help with interpretation services for patients. Maybe that's making sure that staff knows that patients' family members shouldn't be interpreting for them. So the next group of standards is engagement, continuous improvement, and accountability. And you can kind of see on there, this is kind of taking the CLAS standards and making sure that, you are partnering with the community, you're getting input from the community about what services you should provide, and you're making sure that you're accounting for all these, different cultures and languages that are spoken in the area within the populations that you serve. So many of you and your organizations might already do quite a few of these things, particularly in regards to collecting demographic data, just because of all different requirements for different federal grants and different programs. And a lot of times that comes with assessing the community assets and needs, doing some kind of needs assessment for the community, making sure that the community has some way to, file a complaint or bring up concerns if, they feel like something needs to be fixed or changed within your organization, and making sure that you're communicating, what you're doing around these things to all the stakeholders and the general public. So the purpose of infusing CLAS throughout the organization's planning and operation is to, link CLAS to other organizational activities, including policy, procedures, and decision-making related to outcomes accountability, and to integrate it throughout the organization, including maybe in your mission statement. You know, are you there to serve the communities that you're in? You know, what are you doing in relation to that? And while many of you may be required to collect demographic data for various reporting requirements, you know, there's a lot of other reasons why having that demographic data is useful. You know, you can begin to track, you know, how many people come in that speak, you know, Arabic. You know, maybe you need to, you know, hire someone on staff or, you know, contract with another agency to provide someone part-time that can do interpretation services because you have so many people that are coming in that are speaking that language. You can become more responsive to the cultural preferences of your community. You can make sure you're tailoring your services to fit the diverse needs of the population you serve. You can utilize your resources more cost-effectively and becoming more competitive in the marketplace. If you're tailoring all your services to the communities that you're serving, people are going to want to come there, and they're going to recognize that as a place they can go where they can receive services that they feel are appropriate for them. Another thing you can do or have a hand in is an organizational assessment. You know, what is the accessibility of interpreter services? What has your staff had any training on either CLAS Standards or cultural competency? Have you looked at the differences in use of services among different populations? And, you know, maybe since you've implemented something such as some language services, you know, how has that impacted the health status of your patients? So here's an overall organizational self-assessment tool. You can just look at the standard, you know, look at what activities your organization is doing specifically to support that standard. What barriers do you might have? You know, maybe it's a cost issue. What gaps can you identify in meeting this standard, and how are you going to, you know, work to improve addressing that particular standard? And one of the biggest roles that you have is you're able to partner with the community on a much more personal level than leadership or admin of your organization. So you know, what the community needs are. You have community members talking to you every day. You can provide input to your leadership onto, hey, the community says this isn't working for them. You know, how can we address that? I believe one of our health centers that has a location in Page, Arizona, they serve a large Navajo population, and they realized that it was very difficult to have those community members come in and make appointments, so they opened an urgent care facility there as well. And that ensures that everyone is getting access to the primary health care services that they're offering up there in a way that works with them as a community member. So they are increasing the use of their services by, opening the second urgent care facility. So just kind of a few final notes for your role as community health workers. You're the ones that are empowering community members to make healthier choices. You recognize that what works for some members of the community may not work for other members of the community, and you know what barriers are out there that prevent people from making, individual choices, whether it be making it to their doctor's appointment or, eating healthier, or not having the right information to utilize services. So that's about it. We have a bunch of references that we used here. I believe Tracy will be sending out a copy of the presentation and then sent out a bunch of links with all the resources that we referenced here. I know a few people have asked questions throughout. Feel free to ask any more questions if you'd like now. And let's see if we can unmute him.
If you have questions, you can go ahead and type them in the chat and we will answer any. Also, just a reminder for those who joined late, there's actually it's on the GoToWebinar panel, there's a section that says handouts, and if you go there, you'll see the PDFs of this presentation and then also some of those other tools that Emily referenced during the presentation. So you can actually click on those and download them to your computer. You'll also be getting a follow-up email in the next day or so with some of the links to other resources that you can download. And here you see Emily's contact information, and also Hong Chartrand, who's at the Arizona Department of Health Services, also is works in the Health Disparities Center there and does training on CLAS Standards. So she's another good resource if you have additional questions afterwards. Are there any other questions at all? Okay, well, thank you everybody for joining us. Please remember to take just a few minutes to fill out our really short evaluation survey as the webinar closes. And we are very glad you could all join us today. Thank you.